Hello and good afternoon. My name is Dr. Keisha Cash. I am a dermatology certified nurse practitioner working here in the Plant City, Florida area. Today, I'm going to talk to you about the data from the Measure Up 1 and 2 trials and its implications for management of moderate to severe atopic dermatitis. So quickly reviewing the epidemiology, atopic dermatitis is a chronic, relapsing, remitting inflammatory skin condition affecting about 15 to 20% of children and 1 to 3% of adults, making it the most common chronic inflammatory skin condition seen in children. It usually presents between 2 and 5 years of age and is characterized by intense pruritus and skin lesions in typical distribution areas of the flexural creases of the arms and legs. Its causes are likely multifactorial owing to genetics, environmental triggers, and family history. It is associated with other autoimmune conditions such as alopecia areata, vitiligo, inflammatory bowel disease, and rheumatoid arthritis. Much like their psoriatic counterparts, patients suffering with atopic dermatitis also have a higher incidence of cardiovascular disease, heart attack, and stroke, and also have a higher risk of anxiety, depression, ADHD, and substance abuse. The atopic march is defined as the propensity for patients who suffer with atopic dermatitis to have other comorbid conditions and gradually seeing those conditions come to fruition, such as patients starting with atopic dermatitis and then having food allergies, asthma, and allergic rhinoconjunctivitis. Up until now, there have really been no FDA-approved systemic therapy options for these patients. So taking a deeper look, we take a look at this picture of the stratum corneum, and essentially this defines what's happening with patients with atopic dermatitis. This is a picture of the stratum corneum, and essentially what happens are these allergens penetrate the skin barrier through defects in the stratum corneum, and it activates antigen-presenting cells. These antigen-presenting cells then migrate to mature lymph nodes where they stimulate T helper 2 cells. These T helper 2 cells then upregulate pro-inflammatory cytokines IL-4, IL-13, 33, and 31, which then cause the immune dysregulation that leads to atopic dermatitis. It's likely a complex immunologic process that is relative and related to filaggrin gene mutations. And filaggrin is important because it's a protein in the stratum corneum that helps to promote an intact skin barrier. It helps to promote skin hydration. It helps to maintain and normalize the skin's pH. It helps to prevent skin infection and helps to reduce transepidermal water loss. The environmental triggers can be many. As you can see on this picture, grass and pollen are just a few. House dust mites are usually the number one cause, followed by cat dander. But we can also have things like tobacco, smoke exposure, alcohol consumption, antibiotic exposure in utero. We also can have allergies to nickel. We can have allergies to rubber, detergents. We can have allergies irritants like candles, insecticides, pesticides that can also trigger the skin. Things like nickel when we talk about jewelry, belt buckles, maybe even clasps on your jeans that can contribute to skin rash and infection. So when talking to patients about these environmental triggers, essentially what you want to talk to them about is trigger avoidance to help manage their disease. Family history is relative. You always want to talk to patients about their family history, especially if you suspect that the patient has atopic dermatitis. Usually you're talking about first degree relatives like a mom or a dad. You want to ask if they have at least a parent with another atopic disorder. Likely if a patient has one parent that has an atopic disorder, they are about a 3-fold higher risk of having an atopic disorder themselves. And if they have 2 parents, they're at a 5-fold increased risk of having an atopic disorder. So looking at Measure Up in 1 and 2, we had a randomized double-blinded placebo-controlled phase 3 trials that were done in over 20 countries and over 150 clinical centers across the world. It was a 16-week double-blind treatment period, and it had a blinded extension period up to week 260. Eligible patients were patients aged 12 to 17 and adults 18 to 75 that were diagnosed with atopic dermatitis and who were candidates for systemic therapy. Patients were randomized to 3 groups: Upadacitinib 15 milligrams, 30 milligrams, and placebo. At week 16, patients in the placebo group were then re-randomized to treatment groups of Upadacitinib 15 milligrams and 30 milligrams. Patients in both of these treatment groups then continued to treatment on to week 260. The Upadacitinib and placebo tablets had identical appearance to help ensure blinding. So procedures, patients in the Upadacitinib 15 milligrams, 30 milligrams, and placebo groups were given the tab once daily for 16 weeks. They had to discontinue their systemic atopic dermatitis treatments at least 4 weeks before baseline and discontinue topical corticosteroids and calcineurin inhibitors at least 7 days before baseline. These patients were allowed rescue therapy from week 4 if the disease activity criteria were met, and efficacy and safety was assessed at weeks 1, 2, 4, 8, 12, 16, 20, 24, 32, 40, and 52, and every 12 weeks between weeks 64 and 260. So these were the outcomes. We had 2 co-primary endpoints, with patients needing to achieve at least a 75% improvement in their EASI scores from baseline and to achieve an IGA response with a greater than or equal to 2-grade reduction from baseline at week 16. Some of the secondary endpoints to note were the proportion of patients who achieved EASI 90 at week 16, the proportion of patients who achieved EASI 100 at week 16, the patient WP NRS response at week 1, the change in the NRS from baseline to week 16, the ADERM SS skin pain improvement from baseline to week 16, the ADERM IS sleep domain score improvement from baseline to week 16, and the DLQI improvement from baseline at week 16. So here are the key results of Measure Up 1 and Measure Up 2. So as you look here, you see this is the race and medical history for the participants that were in the study. If you look to the left, you'll see the percentage of participants, and you will notice that there were a higher proportion of whites in relative relation to the number of Black, Asian, and other multiracial individuals. This was somewhat of a study limitation, I thought, as we know that a majority of patients tend to have atopic dermatitis are Black or patients of color, and they tend to have more moderate to severe disease. If you look to the right, you'll see the high proportion of patients that reported asthma, food allergy, allergic rhinitis, and acne. This kind of goes to what I talked about before with the propensity for patients to have other atopic disorders, that atopic march, that progression of disease from atopic dermatitis to some of these other atopic comorbidities. And as you can see that the numbers are, relatively high. You have 38 to about 41% of patients reporting that they had other atopic disorders. The acne all the way over to the right is important and relative as we talk about some of the side effects that were reported during the trial. As you can see here, the patients in Measure Up 2 were pretty similar to the patients from Measure Up 1, where a higher proportion of patients that were participating in the study were white and less of the Black, Asian, and multiracial individuals. And as we talked about before, that is a study limitation, but future studies could seek to include more patients of those racial and ethnic groups. When you look to the right, again, you see the high proportion of patients that did report that they suffered from asthma, food allergy, and allergic rhinitis, and then you still had a good proportion of patients that self-reported acne. So moving on to the first co-primary endpoint, we see the number of participants that achieved EASI 75 at week 16. When you look at Measure Up 1 and Measure Up 2, you can see that the patients in the treatment groups far outperformed the patients in the placebo groups, with the percent change from placebo in Measure Up 1 being 53% of the patients achieving EASI 75 at week 16 versus 63% of the patients in Measure Up 1 on Upadacitinib 30 milligrams achieving EASI 75 at week 16. When you look at Measure Up 2, you see similar results where the patients in the Upadacitinib 15 milligram group having a 47% change from placebo at week 16, achieving EASI 75, and 60% in the Upadacitinib 30 milligram group achieving EASI 75 at week 16. You'll notice that the patients in the 30 milligram group did significantly better than the patients in the other 2 treatment groups. Moving on to the second co-primary endpoint, you see the IGA responses at week 16. Much like the previous primary endpoint, when we looked at EASI 75 at week 16, you can see that patients in the Measure Up 1 and 2 studies in the treatment groups outperformed patients in the placebo group. In the Measure Up 1 study, you had patients in the 15 milligram treatment group having 48% of patients responding at week 16 and 39% of patients responding at week 16 in the Measure Up 2 study. When you look at the Upadacitinib 30 milligram group, you'll see the number of patients was 62% responded with their reduction in their IGA scores at week 16 versus 52% in the Measure Up 2 study in those who had a reduction in their IGA scores at week 16. Again, you'll notice that the patients in the 30 milligram group outperform patients in the 15 milligram group and placebo groups. Moving on to the secondary endpoints, we'll see the number of participants that achieved EASI-90 at week 16. Once again, you'll see the patients in treatment groups outperforming the patients in the placebo groups by really large numbers when you really look at it. When you look at the percent change versus placebo in the Measure Up 1 study, you'll see that 45% of the patients in the 15 milligram group achieved EASI-90 at week 16, and you'll see 58% change versus placebo of the patients in the 30 milligram group. When you look at Measure Up 2, again, you'll see similar results with 37% of patients in the Upadacitinib 15 milligram group achieving EASI-90 and 53% versus placebo achieving EASI-90 at week 16 in the 30 milligram group. Once again, the 30 milligram group is outperforming patients in the 15 milligram group and the placebo group. And this is relatively important to note because these patients are achieving about 90% skin clearance with this medication at just week 16, which is really just 4 months into it. And up until now, these patients really haven't had any really viable FDA-approved systemic therapy options. So these are some happy patients that you're seeing here at week 16. When looking at the percent of participants that achieved EASI-100 at week 16, we have not as high as the number of patients that achieved EASI-90, but remember, we're now making this criteria even that more strict. These patients are 100% clearance at week 16. So the numbers aren't as high as those achieving EASI-90, but we're still getting the number of patients to almost 100 to a completely clear skin. When you look at the Measure Up 1 and 2 studies, again, you'll see patients in treatment groups doing better than the patients in the placebo group. When you look at the percent change versus placebo in the Measure Up 1 study, you'll see 15% of patients in the 15 milligram group achieved EASI-100 at week 16 and 25% change versus placebo group in the patients that were on the 30 milligram group achieving EASI-100 at week 16. When you look at Measure Up 2, you have pretty similar results with 13 and 18% respectively percent change versus the placebo in the 15 milligram and 30 milligram groups. Now, this is looking at the worst pruritus numerical rating scale. These are the responders at week 1. So we have these patients that are suffering with atopic dermatitis, an intensely pruritic condition, and we are able to give them some relief as early as week 1. So when we look at these pruritus scores and or results, we'll see that patients in the treatment group did considerably better than the patients in the placebo group, which is relatively consistent throughout the study so far on all the co-primary endpoints and the secondary endpoints that we've discussed. When you look at Measure Up 1 and Measure Up 2, again, you'll see patients in the treatment groups did better than the patients in the placebo group, and you'll see that the patients in the 30 milligram group achieved higher improvement in their itch scores versus the patients in the 15 milligram group and placebo groups. When looking at the change in those pruritus scores from baseline to week 16, you'll see a higher percentage of patients in the treatment groups doing considerably well in relative relation to the patients in the placebo groups. But the Measure Up 1 study showing about 63% of patients achieving the reduction in their itch scores from baseline to week 16 and 73% of patients in the 30 milligram group. And in the Measure Up 2 study, pretty similar results with 51% in the 15 milligram group and 67% of patients in the 30 milligram group achieving a change in their pruritus scores from baseline to week 16. Looking at skin pain measures, we'll see that there was pretty significant skin pain improvement from baseline to week 16 in these patients. Remember, pain being the 5th vital sign, it's very important that we talk to patients about their skin pain and that we measure it accordingly, and then that we try to seek measures that will help to reduce these skin pain measures. And so when we look at these numbers, we see really good results in terms of patients' skin pain improving from baseline to week 16. So at this point now, we've helped to relieve their skin lesions, right? Because we've had patients achieving EASI-75. We got patients seeing a reduction in their IGA score. We have patients achieving EASI-90 and even EASI-100. We also have patients having a reduction in their pruritus scores and a reduction in their skin pain. So when you look at Measure Up 1 and Measure Up 2, you'll see patients in the treatment group in both Measure Up 1 and 2 in the 15 milligram group seeing a 54 and a 49% skin pain improvement from baseline to week 16. And then in the 30 milligram group, you'll see a 64 and 65% skin pain improvement from baseline to week 16 in the 30 milligram group, which is relatively similar across the board in terms of everything else that we've looked at, with the treatment groups doing better than the placebo and the 30 milligram group doing better than both treatment groups. Sleep domain measures. You can't talk about atopic dermatitis without talking about itch, skin pain, and sleep. This is a really good pain measure to look at when we talk about these patients with atopic dermatitis. They notoriously have problems with sleep because they're itching at night. Well, now they will have really good skin clearance, and they won't have the pruritus that they've had before. They won't have skin pain, and they'll be sleeping better. So when you look at these sleep score improvements from baseline to week 16, you see the patients in Measure Up 1 and Measure Up 2, once again, as in all the other measures that we talked about, the patients on treatment outperforming the patients that are on placebo when we look at these scores. You see the percent change versus placebo is marked with 42 and 53% in the Measure Up 1 study in the 15 and 30 milligram groups, and 38 and 50% in Measure Up 2 in the 15 and 30 milligram groups. When looking at quality of life improvement measures, patients' quality of life naturally improved as we help to reduce their skin lesions, as we help to reduce their pruritus, as we help to reduce and improve their skin pain measures, and as we helped and made better their sleep at night. So these numbers aren't surprising when we look at these quality of life improvement that these patients saw from the beginning of the study to the end. You'll notice very high numbers in the treatment groups, with 75 and 82% of patients in the Measure Up 1 study seeing a quality of life improvement from baseline at week 16, and 72 to 78% of patients in Measure Up 2 seeing that quality of life improvement from baseline at week 16. These are the treatment emergent adverse events that were reported during the study in both Measure Up 1 and Measure Up 2. As you can see, I believe that this is a very strong visual to anybody looking at this in terms of being able to kind of relatively pretty quickly figure out and point out where the problems are. When you look at the discontinuation of drug due to adverse events, you have relatively low down at the bottom, with anywhere from 1 to 4% of patients discontinuing the drug due to adverse events. There were no deaths. There were relatively very small serious infections. Most of those patients had eczema herpeticum, which we would expect in this patient population. And the majority of those patients were actually on placebo, which we would expect because these patients weren't getting any drug. The 0% of patients who had active TB, there were relatively low risk of patients with non-melanoma skin cancers. In Measure Up 1, there was one person that had a squamous cell carcinoma, and in Measure Up 2, there was 2 incidences of skin cancer, 1 squamous and 1 basal. Throughout the entire study, there were only 6 malignancies reported. The 3 that we just discussed, a incidence of breast cancer, an incidence of gastric cancer, and an incidence of anal cancer. And none of those were thought to be related to study drugs. So when you look at this and this relatively low risk profile as that is related, you would basically feel like this would help to increase the confidence among dermatology providers that would most likely be prescribing this drug, that they don't necessarily have to increase their skin cancer surveillance in these patients as a relatively low risk of skin cancer formation while using this drug, and none of those that were thought to be related to the drug. The risk of major adverse cardiovascular events, you'll see 0%. The risk of venous thromboembolism was essentially 0%. There was less than 1% risk in Measure Up 2 in a person in the placebo-controlled arm that did suffer from a pulmonary embolism, but that person was not on drug. When you look at the reports of acne, this I put in here because we know JAK inhibitors to have an increase or uptick in the number of reported adverse events of acne. When we talked about this in the first 2 slides, when we started reviewing the data, I showed you that patients had self-reported higher incidences of acne in this group. Most of the patients with anywhere from like 10 to 13% had acne. And when you look at this in the study, you see relatively similar consistent numbers across the board, with anywhere from 2 to 17% of patients having acne-related emergent adverse events. Most were relatively mild. There was one case of a person who had anywhere from moderate to severe flare of acne, which they did discontinue a drug as a result of that. But for the most part, most patients were able to get clear with traditional therapies and did not discontinue study drug. And most of those patients who had acne as a treatment emergent adverse event also had self-reported acne. So when you look at this, this is great. This drug has a relatively low side effect profile. The things that we all worry about as clinicians are that increased risk of serious infection, especially in the age of COVID, the increased risk of death, and the increased risk of major adverse cardiovascular events and venous thromboembolism are relatively small. So you can counsel your patients that this is a safe, effective drug for them to take for the management of their chronic disease. So reviewing the clinical implications and observations, both Co-primary efficacy endpoints were achieved, with patients achieving EASI 75 and patients achieving a greater than or equal to 2-grade reduction in their IGA scores from baseline to week 16. The study evaluated multiple endpoints dealing with the secondary effects of atopic dermatitis on the quality of life and showed that systemic monotherapy treatment with upadacitinib, both 15 and 30 milligrams, would help to reduce patients' skin lesions, help to reduce their pruritus, would help to reduce their skin pain, help to improve their sleep scores, and help to improve their quality of life. When looking at the criteria such as EASI 90 and EASI 100, this could be used as a future clinical treatment benchmark as a minimum criteria for determining treatment efficacy. If we think about this, even just 5 years ago, patients didn't have this potential for skin clearance of 90 and 100% with systemic therapies, with any therapies at all. Most of these patients were doing topical corticosteroids, topical calcineurin inhibitors, and they really didn't even have the potential to have this type of skin clearance. So moving forward with this kind of drug, we can almost expect to see EASI 90 and EASI 100 being clear clinical treatment benchmarks that we should strive to get these patients to almost clear skin. The rapid response to clinical reduction in pruritus was marked. We saw that patients responded as early as week 1, and then the scores all the way out to week 16 were relatively insightful in showing that this drug significantly can reduce itch. In some patients in the study, they even did little cohorts where they showed that patients on 15 milligrams saw a reduction in pruritus as early as day 3, and patients on 30 milligrams saw a reduction in pruritus as early as day 2. A favorable risk-benefit profile was demonstrated when I showed you that graph of the treatment emergent adverse events. These patients don't have an increased risk of discontinuing drug due to adverse events. They don't have an increased risk of serious infection, major adverse cardiovascular events, TB, venous thromboembolism. So you can rest assured that you can safely put these patients on this medication and not worry about a high risk profile. The predominance of white patients enrolled in the study is limiting, as we know that a majority of patients that are suffering with atopic dermatitis are Black and or skin of color patients, and they tend to have more moderate to severe disease. So future studies done on JAK inhibitors and on upadacitinib could hope to enroll more patients of color or to focus on more patients of color. Additional studies to evaluate the use of upadacitinib in conjunction with other therapies would be relative, and it would serve to mimic more real-world scenarios. Oftentimes, patients with atopic dermatitis aren't just using one treatment modality. They're usually on multiple treatment modalities. And so these systemic therapies are relative and are important, and this showed that it can be helpful with just monotherapy. But in real-world scenarios, patients do have flares, and they may need to use topical emollients and moisturizers, or go back and revert to using topical corticosteroids and topical calcineurin inhibitors. Upadacitinib 30 milligrams showed greater efficacy amongst all treatment groups of 15, 30, and placebo, and patients in those groups significantly had greater reduction in pruritus scores and achieving EASI 75, EASI 100, EASI 90, and their quality of life measures with pruritus, skin pain, sleep, and quality of life improvement. So when we think about that, we can rest assured that as we counsel providers on using this medication, we have them start off at the lowest possible dose, but knowing that if patients don't get the skin clearance that they want or get the reduction in those other secondary endpoints of skin pain and itch, as we would hope at the 15 milligrams, we know by looking at these graphs that I showed you today that these patients can safely go up to 30 milligrams and not expect to see an increased risk of adverse events that would cause them to discontinue the drug, an increased risk of serious infection, MACE events, and or venous thromboembolism or non-melanoma skin cancers, despite the fact that they are going up on the drug. So providers can counsel patients that they can rest assured that they can go up on the drug and see a better clinical efficacy without worrying about the risk associated with it. Thank you for watching. My name is Keisha Cash. I am a dermatology certified nurse practitioner here in Plant City, Florida, and I hope to see you guys at maybe some dinner programs around, or you just drop a comment below, and I look forward to talking with you. Thanks, and have a great day.